Great, thank you. So Sudarshan and I are going to do actually a series of clinical vignettes regarding C.diff, and we'll get into some discussion. If there's time, Sudarshan will talk a little bit about fecal transplants in ulcerative colitis towards the end here. There are some audience response questions kind of dispersed throughout the presentation here, so keep your devices on.
So the first case we've got is a 28-year-old female who has a 3-week history of worsening diarrhea up to 4 times a day. She's been recently on antibiotics for a urinary tract infection, but is otherwise well with no other comorbidities. Her initial stool tests showed that on microscopy she had white cells and red cells in her stool. The culture was negative, but the GI panel showed Clostridium difficile toxin positivity. She was treated for presumed C. difficile infection with a course of metronidazole. However, despite this, she had ongoing deterioration, and when you see her about a month later, her bowels are opening 6 times a day or more with streaks of blood, and she's feeling very fatigued and run down. Labs were organised, and she was noted to be a bit anemic with slightly elevated inflammatory markers. And so a colonoscopy was performed, which demonstrated confluent moderate colitis to the splenic flexure. And the histology came back and showed that there was evidence of crypt architectural disturbance and chronic inflammatory infiltrate, which is suggestive of ulcerative colitis. However, she remains C. diff toxin positive.
All right, so we're going to jump right into it here, and one of the main questions to answer in this presentation was, does C. diff trigger a new diagnosis of IBD? And I'm sorry to disappoint everybody who came just for that, for me to answer that question, but there's really a lack of data to answer this question with any confidence, despite anecdotal data that we all have, or anecdotal cases that we all have in our practice where patients have C. diff or another enteric infection and subsequently go on to be diagnosed with inflammatory bowel disease. And it makes sense from a mechanistic standpoint that you'll get this dysbiosis and that could trigger an immune reaction. But really, most indirect data, which is all we have available at this point in time, suggests the contrary hypothesis, or that C. diff is more likely secondary to IBD and not a cause of IBD in newly diagnosed patients. And this really comes from studies examining enteric infections, or at least the well-done studies examining enteric infections have not identified a causal relationship between an infection and the risk of subsequent IBD. If you look here, this is a data from a Danish cohort study where they looked at patients who tested either negative or positive for Salmonella or Campylobacter, and their subsequent diagnosis of Crohn's disease and ulcerative colitis. And you can see that overall, the patients who had negative samples, although maybe a little hard to detect without color, had a higher rate of both Crohn's disease and ulcerative colitis subsequently than patients who had a positive Salmonella or Campylobacter detected. Although keep in mind, both groups had much higher subsequent diagnosis of IBD than patients who did not have samples submitted, indicating this detection bias, or patients with inflammatory bowel disease or newly diagnosed inflammatory bowel disease are more likely to have stool tests done to begin with. In addition, overall rates of C. diff in newly diagnosed IBD patients are low and tend to approximate what we see as a carrier status. And more recently, there's data from the fecal transplant literature, where, as you know, people who have recurrent C. diff infection oftentimes go on to have fecal transplants, which we're going to talk about subsequently in the discussion here. But the transplants are oftentimes delivered by colonoscopy, so it's a good opportunity to identify de novo cases of inflammatory bowel disease. And the largest cohort that was published recently was at the University of Minnesota, and they had 270 transplants, and only 6 new cases of IBD were diagnosed in these patients, and only 3 of these were patients who had a previously negative colonoscopy. So we're talking a rate around 1%. And you can make the argument, well, that's proof that it does occur, but if it does occur, when it does occur, it's relatively uncommon in patients who have recurrent C. diff infection.
Thanks. So the second case is a 40-year-old gentleman with proctitis who's been very well controlled on oral and topical 5-ASA agents, with 1 to 2 formed motions a day, no blood. He was booked for an elective inguinal hernia repair and is otherwise well, but as part of the pre-op screening, they tested for C. difficile and he came back positive. So I suppose we wanted to know, what would you do in this instance where you have an asymptomatic individual who happened to be tested for C. difficile and came back positive? Would you treat or would you not treat?
Oh, excellent. Split 50-50. This will be a good point of discussion here. So just to briefly review, we have several tests at our disposal to diagnose C. diff. Probably the most commonly used test currently is the PCR-based test against toxins A and toxin B. This has the highest sensitivity and specificity, although keep in mind cannot distinguish active disease versus a carrier status. Also commonly used is the enzyme immunoassay against GDH, which is glutamate dehydrogenase. That's an enzyme produced by all C. diff organisms. As such, it cannot distinguish between toxigenic and non-toxigenic strands. The enzyme immunoassay for C. diff toxins A and B is also very commonly used. This is less sensitive than PCR and as such has a high false negative rate, although has a fast turnaround time and is cost effective. And I'm going to show some data on a subsequent slide where a positive enzyme immunoassay against the toxin may portend to a worse prognosis and identify so-called true C. diff infections. And then less commonly used are the cell culture cytotoxicity assay, where they actually culture stool on top of fibroblasts and look for killing of the cell, and then anaerobic cell cultures. And it's important to note that the positivity of these tests is based on the C. diff bacterial load per gram of stool. So on one end of this figure is the PCR-based test, so you need the lowest C. diff load to have a positive PCR-based test. And on the other side of the figure is the enzyme immunoassay, where you need the highest C. diff load per gram of stool to result in a positive test. It's important to note that IBD patients have shown to have a high rate of carriage of C. diff. So when we're talking about carriage, we're talking about patients who have C. diff detectable in their stool but don't have an active infection or an active colitis from the C. diff. This is a study that was done in Ireland where they took asymptomatic, so none of these patients had diarrhea, healthy adults or IBD patients. And you can see that the IBD patients had a rate of C. diff positivity, this is by stool culture, of about 11%, but about 8% of these were toxin-producing strains. And this is in contrast to healthy adults that had a much lower rate of C. diff carriage. The other key point that came out of this study was that the majority of the C. diff organisms that were detected in IBD patients were those acquired in the community. So it brings up the question, are we overdiagnosing C. diff by sending PCR-based stool tests? This was addressed in this interesting study that was done out of UC Davis, where they took a hospital-based study. So keep in mind, it's a non-IBD patient population. They had 1,400 patients who had C. diff sent on clinical parameters, so for the most part for diarrhea. And they sent a C. diff PCR as well as an enzyme immunoassay, but the PCR results were not released to the clinician. So the treatment choice is only based on the enzyme immunoassay results. And you can see here that about a fifth of the patients in the cohort were PCR positive, and of those only about half had a positive enzyme immunoassay. And then when you looked at the outcomes of these patients, the patients with a positive immunoassay were much more likely to have ongoing diarrhea and worse outcomes. If you look at this table on the bottom of the slide here, all the adverse outcomes were associated in this group that had a toxin positive by the immunoassay and a PCR positive test. And when in fact the patients who were PCR positive and toxin negative, and keep in mind these patients did not receive treatment, had very good outcomes overall, which approximated those patients who had a PCR negative test. So it brings up the question, why are we even screening asymptomatic carriers? And this is why. This is data from the Quebec Heart and Lung Institute, where in early 2014 they instituted a policy where they tested all patients by PCR for C. diff, even asymptomatic patients, and they isolated patients who were PCR positive. And you can see that at the point of intervention, there's this divergence in the rates of C. diff infections compared to what was seen in the province as a a whole. And they estimated that to prevent one C. diff infection, you'd only need to isolate 6 patients, and this results in markedly decreased C. diff infections overall.
Thanks. So the next patient's a 43-year-old gentleman with difficult to control left-sided colitis who's on oral and topical mesalamine, azathioprine, and adalimumab. However, he's reporting increased bloody diarrhea up to 6 times a day, despite an increase to weekly adalimumab and the commencement of oral prednisolone. So due to this and ongoing symptoms, he was admitted for presumed acute severe ulcerative colitis for endoscopic assessment and therapy escalation. At the time of his flexible sigmoidoscopy, he was noted to have severe colitis with luminal blood and prominent pseudomembranes. His C. diff toxin that was performed came back positive. So we wanted to find out what you would do regarding managing his IBD flare and associated immunosuppressants, and also managing the Clostridium difficile infection. So firstly, with regards to the C. diff, which antibiotic would you recommend? Metronidazole, fidaxomicin, vancomycin, oral vancomycin, and IV metronidazole. And the next question, would you treat the C. difficile first, await resolution, and then escalate immunosuppression? Initiate treatment of the C. difficile for 2 to 3 days, then escalate immunosuppression if unimproved? Treat the C. diff and escalate immunosuppression for treatment of colitis simultaneously, or send the patient to surgery as he has medically refractory disease?
All right, so the majority would treat the C. diff first before escalating immunosuppression. I'm going to try and go through some of the data behind these treatment choices here. So just briefly to an overview of how we treat C. diff by disease severity. So for patients with mild disease, typically it's recommended to start metronidazole as a first-line treatment, given the cost effectiveness of the treatment and the fact that studies have not shown or not directly assessed a benefit of vancomycin in this population. And keep in mind this is referring to all patients, not necessarily IBD patients. Once you get to moderate disease, however, so these are patients with diarrhea, abdominal tenderness, or dehydration, recent randomized trials have shown that not in IBD patients that vancomycin is likely superior to metronidazole. So really it's a question of cost to the patient versus clinical benefit, which needs to be ascertained in the patients with moderate disease. And then when you're talking about patients with severe disease, so these are patients with bloody diarrhea, pseudomembranes on colonoscopy, fever, an increased white count, low albumin, really vancomycin should be used as a first-line agent, or fidaxomicin, with clinical trials showing equivalence between the two in terms of treatment of infection, with fidaxomicin having less recurrence following treatment. And then in patients who are ill with severe disease, oftentimes we'll add IV metronidazole. IV metronidazole is secreted in the biliary tract and through the intestine into the gut lumen. It's oftentimes recommended to treat with IV metronidazole. There's not a lot of data to support its use in patients with severe disease. And then patients with fulminant disease, those with toxic megacolon or peritonitis, really a surgeon should be involved in the care, although there's case reports of using fecal transplants in patients with fulminant disease. So the one question this comes up frequently is, do you treat the C. diff alone or treat the C. diff and escalate IBD treatment? And this question was posed by one of our former trainees at the University of Chicago, Hanit Yanai, who's now in Tel Aviv. And she did a survey at the Advances in IBD meeting. I believe the survey was done in 2009. This was published in 2011, where she presented gastroenterologists with a couple of cases, and there were 170 respondents. And just like us and our response, the response were equally split between whether they would treat C. diff alone or treat C. diff and add a immunomodulator, and they included corticosteroids in their definition of immunomodulator. Interestingly, although not surprisingly, most IBD experts chose to use vancomycin as a first-line treatment for C. diff. what's the data behind using vancomycin as a first-line treatment? And there's not a lot of data behind this. Dr. Melmed has some data that was published in 2014, where they looked at hospitalized patients who were treated either first-line with metronidazole or vancomycin, and the patients treated with metronidazole who had ulcerative colitis had less readmissions, particularly at 30 days, whether they had non-severe or severe disease. And also, there was a decreased rate in colectomy in both severe disease and non-severe disease, although it did not reach statistical significance. They did not see the same differences in readmission in patients with Crohn's disease, although keep in mind the overall numbers of patients with Crohn's disease were less in this patient population. So this is something that still needs to be addressed in either a randomized fashion or a prospective study, especially in patients with mild disease, as I think there's evidence even in non-IBD patient populations that patients with moderate and definitely severe disease benefit from vancomycin as a first-line treatment option. And the other question that comes up is, does immunosuppression worsen outcomes in patients with C.diff infection? And this was answered in this retrospective study that was published several years ago, where they looked at patients who were treated with antibiotics alone or those treated with antibiotics and immunomodulators. And their definition of immunomodulator in this group was very broad, but included prednisone, azathioprine or 6-MP, methotrexate biologics, cyclosporin, and Tacro. And their primary outcome that they looked at in this study was colectomy within 3 months, death, megacolon, bowel perforation, hemodynamic shock, or respiratory failure. I think we can all agree these are outcomes we don't want to see. And overall, the primary outcome was much more common in patients who received an immunomodulator, and even more common in patients who received multiple immunomodulators. My main concern about the study is that they didn't control for disease activity at baseline. Likely the patients who were receiving multiple immunomodulators were more likely had disease activity related to their IBD at baseline, who would be more likely to have adverse outcomes to begin with. So it doesn't directly address the question of what happens when you increase immunosuppression in patients who are diagnosed with C. diff.
So we now have a 36-year-old lady with a 7-year history of small bowel Crohn's with multiple prior resections. She initially had moderate to severe disease, but it's been well controlled for the past 3 years on infliximab monotherapy. She acquired Clostridium difficile infection after antibiotics for a presumed chest infection. She was initially given a course of metronidazole for 10 days, but still had ongoing diarrhea, and subsequently went on to a course of vancomycin, 125 milligrams QID for 10 days. This led to a temporary improvement in her symptoms, but after 2 to 3 weeks, the symptoms recurred. So a colonoscopy was then scheduled, while a further course of vancomycin followed by pulse dosing was prescribed. The colonoscopy showed patchy non-specific colitis with no definitive pseudomembranes and no evidence of active small bowel disease in the interrogated neoterminal ileum. And she still had persistent C. difficile toxin positivity and ongoing symptoms. The patient then inquires about FMT. So would you offer this patient a fecal transplant? Yes, they've failed multiple courses of antibiotics. Yes, it will improve and treat their UC. No, it's too risky in the setting of IBD. Or no, they're likely to colonize with Clostridium difficile and symptoms are likely related to active IBD.
All right, so people want to pursue the FMT in general. There's some concern that this patient is colonized. So let's talk a little bit about fecal transplant. Really, there's 2 main indications for pursuing a fecal transplant in the setting of C. diff. One is for patients with refractory disease. So these are patients who are not responding to antibiotic treatment, and the other is for patients with recurrent disease. So the current guidelines recommend that that to pursue a fecal transplant, a patient should have at least 3 recurrences of C. diff, with at least one of these recurrences being after a pulse vancomycin taper, or having at least 2 episodes of severe disease that required hospitalization. As most of you know, FMT can be administered through several routes: enema, colonoscopy, an upper GI approach, or more recently, fecal capsules have been developed and are available. This is a meta-analysis looking at the comparative efficacy of the different routes of administration of fecal transplants. Keep in mind this only includes 2 randomized studies, but overall the rate of response or prevention of recurrence is best with colonoscopy, about 90% across studies, although the other methods of delivery, including enema or an upper GI approach, are very effective as well. So how does FMT compare to treating with another course of antibiotics? This was answered in this randomized open label study, where they randomized patients who had what we would typically define as recurrent disease, so multiple recurrences of C. diff infection, to a short course of vancomycin followed by a fecal transplant given by stool installation by colonoscopy, and then stool enemas every 3 days if they had pseudomembranes present on that colonoscopy. And then the control group was given a pulsed prolonged taper of vancomycin. And you can see that the outcomes in the study, which were assessed at 10 weeks for recurrent C. diff and diarrhea, were much less common in the FMT group, so 90% effective in the study compared to 26% who received vancomycin. And these results are fairly similar to an earlier randomized control or randomized Dutch study that was published in the New England Journal in 2013, where they gave the fecal transplant by duodenal infusion. So if you want to do this at home, what do you need to do? You need to find a donor, and you need to screen the donor stool and serum for infectious organisms, and then you need to do a social screen on the donor as well. And then ideally, they should not have had antibiotics within the last 3 months, and it's generally recommended to avoid comorbid GI diseases as well, including inflammatory bowel disease and GI cancers. Some recommend not including patients with irritable bowel syndrome, although as many gastroenterologists in the room can attest to, given the overall prevalence of IBS in the population, you're really going to limit your donor pool if you don't include patients with IBS. On the bottom here, for your reference, I listed a site that the AGA has where they list billing codes for the recipient to screen donors for the transplant. And then the stool needs to be processed, and it's relatively simple to process the stool, although you need the manpower and the facilities to do it. Essentially, you take the stool, mix it with water or skim milk, place it in a blender, and filter it through gauze, and then use it within 6 hours or freeze it down for future use. But it should be done in a BL2 certified hood, and you should use a laboratory grade blender that needs to be cleaned thoroughly afterwards. Some have advocated actually for just buying a cheap blender at Walmart and then throwing it out after one use as well. So you can consider this. You can also consider purchasing pre-screened and processed stool, such as through other programs such as Open Biome, which we've been doing at the University of Chicago, and this is really streamlined and provided better access to providing FMT for patients with recurrent C. diff infections. So in terms of delivery, so keep in mind that protocols are not standardized, and the delivery methods have not been very well studied in terms of comparisons of different delivery methods. It's generally been, in most studies, and what we'll typically do is continue vancomycin until 24 hours prior to the procedure, and then do a bowel lavage prior to this procedure, obviously for a colonoscopy. For the deliveries that I've done personally with an upper GI approach, I do a bowel lavage as well, although that's not standardized across studies that have looked at upper GI delivery of FMT. And then when we do colonoscopy, we try and deliver the stool into the ileum and or cecum, and then following the procedure, we place the patient in reverse Trendelenburg, and we'll give loperamide. I'll typically give 4 milligrams in the recovery area after the colonoscopy. Even with loperamide, some patients still have a bowel movement in the recovery area, passing some of the FMT. That doesn't necessarily not necessarily been associated to be with a decreased response to the FMT, however. You can also give the FMT by flexible sigmoidoscopy or by enema if there's a contraindication to doing a full colonoscopy in the patient with success, or an upper GI approach, although keep in mind it's recommended if you deliver the stool to the stomach or duodenum, you should use a lower volume of stool. So a couple key points. So what's the outcome of FMT in immunosuppressed patients? And overall, the outcomes look to be good, although the data is limited. Most of the data it comes from this study that was published in 2014 in the American Journal of Gastroenterology, where they looked at 132 patients that were identified in previous either case reports or retrospective studies, who are all on immunosuppression. And overall, the efficacy appears to be similar to non-immunosuppressed populations, and infectious complications are rare. The major adverse effects were seen, unfortunately, mostly in patients with inflammatory bowel disease, coming from a flare of their IBD in about 15% of the patients in this cohort. Keep in mind also this data surrounds patients with recurrent disease and less with refractory C. diff infection. More recently, data has been published from the University of Minnesota, where they've looked at their fecal transplants in IBD patients. And they've done transplants on 272 patients. 43 of these have had IBD. And overall, the response rates in IBD patients in terms of clearing the C. diff or preventing recurrent C. diff is significantly lower than non-IBD patients. So about 3/4 of patients with IBD we prevent recurrence with FMT, whereas it's over 90% in patients without IBD. And also important is that in this study, about 1/4 of patients reported a clinically significant flare of their disease or flare of their IBD after the FMT. And if you look at this table below, the factors that were associated with not responding to the FMT, the one that stands out is having inflammatory bowel disease. And in fact, immunosuppression alone, if anything, was associated with a trend towards being beneficial in terms of responding to the fecal transplant. So now, before we conclude, I'm just going to flip the switch and present a case for Sudarshan to answer, given that he's our expert in giving FMT for ulcerative colitis. So this is a 37-year-old patient who was referred to us for fecal transplant. He has a history of ulcerative pancolitis, and he's had recurrent C. diff infections. And the referral was a request for fecal transplant. And despite being on vancomycin, on a pulse prolonged taper of vancomycin, he had a negative C. diff PCR prior to the transplant, but was still having 8 bowel movements per day. So we went ahead and did the fecal transplant, and at the time of the colonoscopy, he had mild pancolitis, so a Mayo endoscopy score of 1. After the transplant, 2 days later, he calls up complaining of cramping and bloating and some diarrhea. And we said, don't worry, we see this typically after transplants, it's going to get better. And we didn't hear from him for about a month. And he comes into clinic a month later, and he shows up and says he's perfect. He's having formed stool without urgency or blood in his stool. So my question for Sudarshan is, did the FMT treat his ulcerative colitis?
Well, I suppose it's a little bit difficult there. With regards to FMT and ulcerative colitis, it's quite an exciting area of research at the moment, but the data is quite limited. We've only got 3 controlled trials to date, which are conflicting data. 2 are positive, 2 are negative, 1 is negative, but they vary in terms of their infusion protocols, route of administration, number of infusions given. I think the main points that we can gather so far with regards to FMT and IBD is that it's not like C. diff. It's nowhere near as effective, and if it is going to work, it generally requires more than a single infusion. So this patient had a single infusion and is better. There's sporadic cases like that, but it generally wouldn't be the norm. I think in terms of FMT and IBD moving forward in the field, it's probably going to be a matter of trying to match donors with the patients. I think you're going to have to be specific about the type of donors that you have. Unlike C. diff, it's not one donor meets fits all. So I think that's where the field's heading, and hopefully in the future we'll have some actually more characterized microbial consortia that we can use to actually treat the condition.
So just to finish up here, so a couple key points to take home with you. So overall, C. diff is common in IBD patients, and I didn't get into this, but the classic risk factors of antibiotic exposure and pseudomembranes are rare. It can be difficult to distinguish between active disease and asymptomatic carriers in both IBD and hospitalized patients overall. Generally, it's recommended to use vancomycin as a first-line agent for severe disease and consider it a non-severe disease in high-risk individuals, such as those with inflammatory bowel disease. And FMT is very effective in treating recurrent and refractory C. diff infection, although keep in mind some of those safety data, particularly long-term safety data, is limited at this point. And there's newer therapies that we didn't have time to talk about that targeting the microbiome, such as spores from healthy donors or non-toxigenic spores of C. diff or cocktails of synthetic bacteria, which may be additional options in the future with an improved safety profile overall.